Thank you so much. It's a very old topic and a very big topic. I don't know how will I justify this for this 6-minute talk, but so I will go a little faster. So as we all know, the thoracolumbar region is a unique region in the spine and uniquely positioned between the rigid thoracic spine and the mobile lumbar spine. And this transition at the thoracolumbar junction subjects it to a significant biomechanical stresses and making this thing. Another point that makes this unique region is the neurological involvement due to injury to conus of the spinal cord, and a myriads of combination of neurological involvement hence are possible with thoracolumbar fracture. So if you see this X-ray, this is an X-ray of a girl who was 18 years, history of fall, had this fracture. She was neurologically intact but presented only with a bowel and bladder involvement. So that is so unique to this thoracolumbar region. Patient can have only bowel bladder involvement and nothing else. But when we treat these fractures, there are multiple questions which come to our mind. Some of them are: what classification should be used when we want to classify this? How do I define instability? Whether cast bracing can be used to unstable or unstable burst fracture? What is the ideal time for the surgery? What is the ideal time for decompression in neurological deficits? If neurology is intact, whether to operate or not? Which approach to use for surgical decompression of neural tissues? Is decompression indicated for complete spinal cord injury? Can I put pedicle screw in the fractured vertebra? Can I avoid anterior reconstruction by long segment posterior fixation in unstable thoracolumbar burst fractures? And is methylprednisolone really useful? So these are very important questions, dilemmas that come across our mind, and these answers have been, this talk has been going on for years now, and over all these years we have tried to, add brick by brick to make our understanding better over all these years. So what classification to use? So ideal classification should be comprehensive, it should be usable, it should be accurate, predictable, and it should guide intervention. But unfortunately, we are still seeking it. This is the history of thoracolumbar classifications, starting from Holdsworth, Whiteside, Dennis classification, McAfee classification, low shearing classification. I'm not going to details of it. And the last one is TLIX classification, which was given by Dr. Vaccaro. Now what we are doing is we are looking at AO TLIX, which is the newer one, which is a new pigeon in the cage, and I mean, it promises a lot of things, but still I think a lot of work and validation is required before we actually adopt it in our system. Differences between AO and Dennis. AO was based on basically 2 columns, Dennis was in 3 columns, and there were some differences, but the reproducibility of Dennis was better than AO, and thereby AO went into this was the initial AO, and it went into disrepute because of the poor reproducibility of AO classification. And later came the TLIX classification, which seemed to be an acceptably reliable system when compared to the Dennis and the AO system. And there is a base level of knowledge and familiarity necessary for the application of system at reliable levels. So the classification of thoracolumbar injury has evolved significantly over the course of last 75 years, and most of these schemes were limited by their complexity, relevance, and poor reliability. So the TLIX classification, which came in 2005, I suppose, the TLIX classification system represents an evolution as it combines several important factors, and but there were still some limitations to the TLIX classification, that it focused mainly on the PLC neurology and the morphology of the fracture. But additionally, there is, neurological scoring can be impossible during spinal shock, which was not taken into account. Additionally, there is a need to determine the indirect radiological parameters of unstable spine. TLIX does not describe surgical stabilization in case of rotational damage. And similarly, burst fracture, you may have different points, and you may actually land up doing conservative treatment for burst fractures with TLIX classification, in spite of kyphotic angulation and burst. Neurological involvement was not there. This is the recent one which I was talking about, the AO TLIX, which is but it is still not completely validated. The multicentric validation is still pending, and if we compare this classification to the TLIX classification, it includes all the components needed for decision making. It has good intra-observer reliability, and its most comprehensive classification as of now at present. So let's come to the second. How do I define instability? Why is it important to look for instability? Instability is the key to therapeutic indications because it equates in many cases with the need for internal stabilization, first defined by Holsworth. So PLC was, rupture of PLC was made as, was not compatible with stable biomechanical studies showed that complete rupture of posterior longitudinal ligament or complex alone is not sufficient to establish instability. Additional rupture of the posterior ligament is complex. Posterior annulus fibrosis permits instability in flexion. And this was Whiteside, Magal, Dennis classification. A stable spine is one which can withstand axial forces. Telex took in the white and Punjabi definition of this thing. Whether cast bracing can be used? Yes, it can. A thoracolumbar burst fracture and exclusion of an associated posterior ligamentous complex injury is inherently a very stable injury and may not require a brace. Non-operative management of thoracolumbar burst fractures with hyperextension casting or bracing was proven to be safe and effective. I don't think I can finish this, so I'll just go to the final take-home message because it's a big topic. It's impossible to do a justification for this. I'll just answer the dilemmas and the crux of it. So the take-home message from this talk is what classification to use. As of now, there is no system which completely predicts. Careful classification will guide optimal treatment of a particular fracture type. How do I define instability? A stable spine is one which can withstand axial forces anteriorly, tensile forces posteriorly, and rotational forces, so as to hold the body erect, protecting the contents of the canal and preventing progressive kyphosis. Injury to PLC is a main indicator of instability. Okay, so whether cast bracing can be used in stable, unstable burst fractures, hyperextension casting or bracing was proven to be safe and effective method for selected patients. What is the ideal time for surgery? Ideally, patients with unstable thoracolumbar fracture should undergo surgical stabilization of their injury to reduce morbidity and possibly mortality as soon as the general condition is stable. What is the ideal time for decompression in neurological deficit? Evidence suggests that early decompressive surgery in selected patients may enhance neurological recovery. If neurology is intact, whether to operate or not. In thoracolumbar burst fractures without a neurological deficit, there is no superiority of conservative therapy over operative therapy, except in polytrauma patients in whom the surgery has better results. Which approach to use for surgical decompression for neural tissues? So if we go back in the history, anterior decompression has always provided better strut grafting, fixation yields and good results in terms of neurological recovery. Is decompression indicated for complete spinal cord injury? Should we do decompression when we deal with ACI injuries? So spinal canal stenosis is poorly correlated with neurological dysfunction in thoracolumbar burst fractures, and surgical decompression is not vital to neurological recovery. So you can only do it in terms of if you are planning to avoid late development of post-traumatic syringomyelias. Can I put pedicle screw in fracture vertebra? Yes, reinforcement with fracture level screw combination helps to provide better kyphosis correction and biomechanical stability. Can I avoid anterior reconstruction by long segment posterior fixation in unstable thoracolumbar burst fractures? Lumbosacral instrumentation is a more effective management of thoracolumbar burst fracture.